This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We're in Columbus, Ohio. It's episode 76 for June 20th, 2022. We're calling this one Eosinophilic Esophagitis. I want to welcome all of you to the program. So we have an important episode for you today because the topic is a medical condition that is, somewhat common, but it often results in a delayed diagnosis, sometimes prolonged suffering, and sometimes unnecessary complications because it may not be the first thing we think about when a patient presents with upper abdominal pain and or dysphagia, sometimes some chest pain, some vomiting. And the condition we're talking about is eosinophilic esophagitis, as I mentioned, and that is becoming more common, not only because it actually has an increased incidence overall, which we're seeing with all allergic type diseases. So this one kind of falls into that same category as asthma, allergic rhinitis, atopic dermatitis, or eczema. All of these conditions are increasing in incidence, but we're also seeing more awareness about this particular condition. So more people are being sent to the GI doctors for this set of symptoms. More of them are having the biopsies done. And so eosinophilic esophagitis is being diagnosed more, which also contributes to the increased incidence compared to years past. And when we think about this set of symptoms, upper abdominal pain, some chest discomfort, some difficulty swallowing, the first condition we might think about is gastroesophageal reflux disease, which, as it turns out, GERD is often present along with eosinophilic esophagitis. However, we're not really sure about the exact character of that relationship. Does GERD cause EOE, which is short for eosinophilic esophagitis, because that's a mouthful to keep saying over and over again? Does GERD exacerbate underlying EOE, or is GERD caused by EOE? So we're going to explore the relationship today between those two things. We'll also talk about the signs and symptoms of EOE. How is it diagnosed? How is it managed? What complications can we expect? How could we possibly prevent it? All the things as we consider eosinophilic esophagitis. And to guide us on the path, we have two terrific guests joining us this week. Dr. Elizabeth Erwin is a pediatric allergist at Nationwide Children's Hospital, and Dr. Rajitha Venkatesh is a pediatric gastroenterologist, also at Nationwide Children's. Before we get to them, let's take a moment to cover our usual reminders. Don't forget you can find PediaCast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android, including Good Pods. That's a new one that we're in. If you like what you hear, please remember to subscribe to the show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know exactly what to expect. Speaking of that educational credit, it's Category 1 credit, it's free, and it is easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. We also have that handy contact link over at PediaCastCME.org if you would like to suggest a future topic for the program. Also, and remind you, the information presented in every episode of PediaCast CME is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Our discussion may contain only a portion of relevant information and should not be solely relied upon for the diagnosis or treatment of any medical condition. We do not cover every possible treatment option, and the treatment options we do cover do not include every possible use, precaution, side effect, or interaction. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Rajitha Venkatesh and Dr. Elizabeth Erwin settled into the studio, and then we will be back to talk about eosinophilic esophagitis. It's coming up right after this. Dr. Rajitha Venkatesh is a pediatric gastroenterologist at Nationwide Children's Hospital and an assistant professor of pediatrics at The Ohio State University College of Medicine. Dr. Elizabeth Erwin is a pediatric allergist at Nationwide Children's and an associate professor of pediatrics at Ohio State. They're here to talk about the who, what, when, where, why, and how of eosinophilic esophagitis. But before we go down that path, let's say hello to our guests. Welcome to PediaCast, and thank you both for joining us today.
Thanks, Mike. Thanks so much for having us, Mike.
Yeah, really appreciate you guys taking time out of your busy schedules and stopping by to talk about this topic. Let's just start with a basic definition. Rajitha, I wanted to start with you. What exactly is eosinophilic esophagitis?
Absolutely. Thanks so much. So eosinophilic esophagitis, or EOE or EE, is a chronic immune-mediated clinical pathologic disease of both kids and actually adults as well. So really, it's a disorder of the digestive system in which large numbers of a particular type of white blood cell called eosinophils are present in the esophagus. And that esophagus is a tube between the mouth and the stomach. And eosinophils are actually part of our immune system and play a really important role in immune regulation and fighting against infections, and is a hallmark of what we call allergic diseases. So this condition we're going to talk more about today, but it's characterized by vomiting, stomach or chest pain, failure to thrive, difficulty swallowing, and food getting stuck in the throat. And also there's some subdivisions of EOE as well.
Gotcha. So when you say it's an allergic disease, it's in that same realm as like asthma, allergic rhinitis, atopic dermatitis, or eczema. It's kind of in that same grouping of things.
It's a great question. Yes, it's absolutely associated with sort of the atopic conditions that you mentioned. But what's interesting is that it's a very different type of inflammation than what you would see when you have like an EpiPen type of reaction.
Yeah. And we'll talk more about exactly what that reaction looks like. First, though, Elizabeth, how common is eosinophilic esophagitis and who is at risk?
Well, it's actually still considered a rare disease. However, it has increased by incredible amounts. Some estimates say it's increased by 30 times. It was seen as early as the 1990s, but has increased so dramatically that now here at our hospital, we probably diagnose it as often as celiac disease, which is much more well known. So,
yeah. Would you say that it's really increasing in prevalence, or are we just recognizing it more and diagnosing it more, or maybe a combination of those things?
Yeah. That's a question that's debated in the field. People who have been doing scopes, though, and taking care of patients during this time period say that there's no doubt in their mind that it's increasing too, that they're seeing it far more. But we are definitely more aware of it and looking for it too.
Yeah. In the adult population, it's reported about 5 cases per 10,000 people, and the numbers that I had come across, somewhere between 1 to 2 kids per 10,000. Does that sound like pretty close numbers to you? And then is there a difference between boys and girls?
Oh, right. Yes, for sure. It's diagnosed more often in boys, and we're not sure why.
Yeah,
definitely.
And what about ethnicities and races? Is there a difference in that regard, or does it pretty much affect everybody across the board?
There seems to be a difference. I'm not sure if we know the end of the story there, but definitely right now it's more commonly diagnosed in Caucasian patients.
Yeah, and that could have something to do with access to healthcare and healthcare disparities and like who's getting in to get the scopes and get the diagnosis.
For sure. I think that's why, it's not clear yet because there could be other factors influencing those data. But yes, it's more commonly white patients right now.
Okay. And then in terms of age within the pediatric population, I think I saw the mean age was about 9 years old, which kind of tells me that it affects everyone from school-age kids up through teenagers, and 9 is kind of in the middle there.
Yeah, for sure. That's probably the mean that we see most often. When we drill down and look at epidemiologic studies, though, there seem to be maybe 2 peaks. So there are early peaks in children as young as 1. And then also a lot of teenagers are diagnosed when they end up with symptoms that are very classic.
Yeah. So, but we should think about it really in any kid who
sure.
of any age who has the symptoms, which we'll talk about here more in a minute.
Absolutely.
Before we get there, I wanted to talk a little about the pathophysiology. So we know the immune system is at play. We've already talked about that. And then stomach acid, at least initially, we thought that played a big role in this, but now we think maybe it's not quite as big of a role, but it's not necessarily no role. So how does gastroesophageal reflux disease and stomach acid play into this, and what other things are at play?
Yeah. Well, that's probably $1 million question in the field. Definitely, there's a tight connection between patients having acid reflux and EOE, and it's almost like a bit of a spectrum to some degree. But stomach acid perhaps may be responsible for some of the effects that we see on cells in the biopsies. Besides seeing eosinophils or the allergy cells that Dr. Venkatesh mentioned, we see that the intracellular spaces are dilated, which from a pathophysiologic standpoint may provide more gaps or less tight junctions to allow for antigens to get into the mucosa where our immune system might end up encountering them rather than just passing through the esophagus and moving to the other parts of the GI tract.
Yeah. So stomach acid may play a role. And then we also know that the immune system plays a role. What about genetics? Does this run in families? Are some people more prone to it than others, kind of like we see with other allergic diseases?
It does run in families. Strangely, this was a disease that was described more in pediatric patients first. So sometimes, children are diagnosed before older relatives, but very often when we're talking to our families, they'll mention another person in the family who has similar symptoms, and sometimes they've been diagnosed, but often it's just a history of symptoms that are similar to the patient we're seeing. But
then that may help those other family members who didn't know what the cause of their problem was. But now that there was a pediatric diagnosis, that you can see that would be pretty beneficial for the family. Yeah,
for sure. I think overall the original estimates probably thought that maybe 10% of cases had a family history. When there's been very few studies so far, but the one study that was done said that probably siblings have an increased risk of 3% over that 0.05 that you talked about as the general risk for having EOE.
Gotcha.
And twins an even higher risk.
Mm-hmm. So definitely a genetic component, acid component, immune system component. Rajitha, as we think about all of those things, we mentioned that there's some conditions that it's related to. Do you see that so if someone has an allergic condition like asthma, allergic rhinitis, atopic dermatitis, are they more likely to then also have eosinophilic esophagitis? Are they really associated with each other?
Yeah, it's a great question. And actually part of the reason why we have our multidisciplinary program here at Nationwide Children's is that exactly for those reasons, that people with atopic dermatitis, asthma, food, environmental allergies, they do have a greater chance of developing EOE. And then some other conditions can also cause eosinophils to increase in numbers. So it's really important to be able to distinguish that if the patient has EOE or other additional things, things. So we think about reflux, other types of eosinophilic GI disorders called EGIDs, IBD infections, even things that, like you mentioned, family history too, are really important to take into account.
Yeah. So you mentioned food allergies, which is not one of the allergic conditions that we had mentioned, because I kind of think of that one as kind of its own thing compared to the atopic ones, if that makes sense.
Absolutely.
Is it, when we think about food allergies and eosinophilic esophagitis, is it a contact issue with the food, or is it more of a systemic thing that just happens to take place in the esophagus?
It's a great question. Actually, I'm going to ask Dr. Erwin because we do work together a lot for this exact reason. And the way we often describe it is that it's more of a topical sort of reactions happening in the esophagus, but unlike IgE-mediated food allergies. But often our patients can have these EpiPen type of reactions as well.
Yeah, I think that's something that really is interesting and puzzling for us because it's clearly, EOE is not an IgE-mediated response to food. So it's not the same as the food allergy that we've traditionally thought of, where patients have anaphylaxis or hives. But the patients who have those types of food allergies are by far at a greater risk for having EOE too. So then this other kind of food allergy as well. So when we look at it in reverse and we look at populations of or cohorts of EOE patients, about 30% of them have a typical IgE-mediated food allergy too.
Yeah. So if there's a problem with one component of the immune system, there may be a problem with another component of the immune system, but this is more of a cell-mediated response rather than an IgE mediated response. And then there are other associations that are a little bit less clear that I was reading about. So people who have gluten sensitivity, history of inflammatory bowel disease, some connective tissue disorders, antibiotic exposure in infancy, which, pretty much all infants are exposed to them. So it's kind of hard to tell, whether that's really a cause or not. But so there's a lot of other things that can be associated with this that we should be thinking about. All right. So let's move on to then the signs and symptoms of eosinophilic esophagitis. Rajitha, what, as primary care providers, when a patient comes in with a set of symptoms, what are we looking for where this diagnosis ought to be in our differential?
Yeah, absolutely. And primary care providers provide an essential role for this because symptoms of EOE can actually vary a lot from one individual to the next. And actually, it differs depending on age. So particularly in pediatrics, where we think about infants and toddlers who often refuse their food or have trouble growing properly, or school-age children who have recurring abdominal pain, trouble swallowing, or vomiting even. And then sort of adolescents and adults who have maybe more difficult or painful swallowing are actually able to tell you that. Their esophagus actually may narrow and can even cause food to become stuck, also known as a food impaction, which is a medical emergency. And we actually know that the number one reason for food impactions, particularly in the adult ERs, for example, is EOE. And truthfully, the symptoms can really vary mostly because of the developmental ability and communication skills of the age group affected. But common symptoms include reflux that, for example, may not respond to acid medications. So that can really span infant, childhood, and into adulthood. Difficulty swallowing, particularly in older children and adolescents and adults. Food impactions that we mentioned. And then in younger kids, we often think about nausea, vomiting, failure to thrive, also in terms of poor growth, malnutrition or weight loss, poor appetite, and even feeding refusal, for example, or difficulty sleeping due to chest or belly pain, which is quite a range of symptoms for sure.
Yeah. So, as we think about pain in the esophagus, difficulty swallowing or pain with swallowing, chest pain, abdominal pain, vomiting, those all come to mind. But those behavioral symptoms that you were mentioning, especially in younger kids, may be something that kind of clues you in for the first time that something's wrong with feeding. So if you have a kid who's dropping off on their growth chart and maybe their eating habits have changed, maybe they eat more slowly or seem to be chewing excessively or drinking larger and larger amounts of fluid with their meals. That could all give you an indication from a behavior standpoint.
That's exactly right, Mike.
Something's going on.
And that's actually a great way to explain it because it's almost a coping mechanism that children have developed to protect themselves from those food impactions. So by, for example, one of the things I mentioned to families is if you're at a restaurant, you stop eating when the water runs out at your table, for example, that's a way for them to protect themselves. Or if they chew for a very long time and have extended meal times, those may be some smaller clues that they're trying to express that discomfort that they're trying to avoid.
Yeah, absolutely. So then, Elizabeth, as we think about the differential diagnosis of those symptoms, I think for a lot of us, eosinophilic esophagitis may not have really even entered into the differential, and it should, but there are some things that typically would, like gastroesophageal reflux disease, for example. Sometimes constipation can cause, not eating as well, and, chronic abdominal pain. As we think about drinking more fluids, we might even think about diabetes. So what are some ways that we can differentiate, especially gastroesophageal reflux from eosinophilic esophagitis, but other disorders too?
It's probably a bit tricky. I think when we try and explain to people how to differentiate, we, probably start with the assumption that it's gastroesophageal reflux, since that would be more common, and start some sort of treatment plan for reflux, which often includes taking medication to suppress acid production. And then I think for EOE, those are the patients who, you may try and stop their acid reflux medication after they've been on it for a few months, just thinking that this was a temporary problem. And if they're unable to come off the medication, then I think that's a patient where you might want to start to think about something beyond simple acid reflux.
Yeah. So it would make some sense to try to treat it as you would standard reflux. And if it is EOE and those things work, then great. It didn't really matter whether you differentiated which one it was if their symptoms are under control. But if their symptoms are under control with your typical treatment for reflux, then you do want to start thinking about this.
Mm-hmm, for sure. And we even, I think for a patient too who does get under control, but if it just goes on, and typically patients will try and stop their medicines on their own, rather than taking something for the long term. And if they come back to you, they've stopped the medicine and they come back and their symptoms are, right back, then that is a person where we may want to distinguish between the two diseases and actually have them see a GI doctor so that they can get perhaps further evaluation.
Yeah, that makes sense. From a primary care perspective, this is probably not a diagnosis that we're going to be making in the primary care office. We may think, it could be reflux and, try antacids or H2 blockers or proton pump inhibitors, those kind of medications. But I think the next step is probably referral to a GI specialist to really tease out what's going on, since those initial things didn't help. So then from your perspective, Rajitha, how does the GI doc go about diagnosing this condition and differentiating it from the other possibilities?
Yeah, no, it's a great question. And that's actually where we often start off, because a patient may already be on some medications, but in terms of differentiating their symptoms, ultimately this is a clinical pathologic diagnosis, to meaning that ultimately an endoscopy is often needed to really distinguish if this is in fact EOE, because we do use the symptoms as part of this, but we also need the mucosal sort of inflammation identified, and specifically eosinophilic inflammation, and to help rule out some of these other potential causes. So an endoscopy is going to be an important role as a gastroenterologist in that diagnosis.
Yeah. So you're putting a scope down, you're getting a tissue sample, looking at it under a microscope, or the pathologist does. And if there's a lot of eosinophils present, then that gives you an idea that this is going on?
Yeah, it's a great question. So visually, we'll usually have some ideas. So we often see things, we have an endoscopic scoring system that we actually use called an EREF score, where we look to see if there's edema or swelling of the esophagus, looking for exudates or even these sheets of eosinophils, even things like furrowing, as well as strictures and rings. So even visually, you often have an idea at the time of the endoscopy, but exactly right. We need the mucosal biopsies as well to help confirm the diagnosis and to help rule out other causes for this as well.
Yeah. So let me just focus in on that really quick. And what you're saying, I think, and please correct me if I'm wrong, but that when it's immune mediated, we're going to call it eosinophilic esophagitis. But there are other conditions in which there could be eosinophils in the esophagus that aren't necessarily that immune system related type?
That's a great question. Yeah. So when we think about eosinophils, we actually have a cutoff to help identify that. So if we see above 15, particularly at 1 or 2 levels of the esophagus, that is part of the diagnostic criteria for EOE. But certainly things like reflux, even IBD, other infections, other types of malformations or injuries can also cause some eosinophils. So sort of taking all that in context with the history, with the visualization that we have from the endoscopy, the biopsy, biopsies and sort of putting that all together.
Yeah. So you're synthesizing a bunch of data points, using some critical thinking skills and coming up with that as your diagnosis. And let's say that in an individual patient, you do determine that their symptoms are caused by eosinophilic esophagitis. How do you go about treating it then?
Yeah, no, this is definitely a great question because there's a lot of changes. This is such a new disease that I think even in our lifespans, things have developed rapidly in terms of research and understanding of this. So the main treatments recommended for EOE are really diet management, medication. So we sort of talk about drugs, dilation, and diet, and actually decreasing dysphagia. And I'll talk a little bit more about that. But diet therapy and also just the fact that we need repeat endoscopies with biopsies to really monitor the effectiveness of treatment plans. But diet therapy involves removal of suspected or known food triggers. Often this includes removing common allergy-causing foods such as milk, wheat, eggs, soy, peanuts, tree nuts, fish/shellfish. However, almost all foods have been implicated, and some patients may simply be allergic to a single food, while others may actually be allergic to many foods. And for some patients, elemental nutrition may be recommended to supplement the diet or for full nutrition. And that actually consists of special amino acid-based formulas that don't elicit that allergic response. And that's actually how this disease was first identified, was when initial studies were done with elemental diets, is that it completely healed the esophagus. So if a patient has difficulty drinking sufficient amounts of formula, or for other reasons, they may also need a temporary feeding tube to help with that, or a more long-term alternative called a G-tube as well. In terms of medications...
Actually, can I just stop you really quick? I'm sorry. Before we get too far away from diet, I had a couple of other questions for you. It would seem to me that if you can identify specific triggers, that's going to be better than saying, oh, you can't eat all of these foods, especially as we think about nutrition and growth and development and how that's all interrelated. So is there a way to figure out like specific food triggers? I guess one would be if you eliminate them one at a time and what helps, but that's going to take a long time and serial biopsies and all of that. Oh, I guess you could monitor symptoms as well. Or I know the blood tests for food allergies aren't that fabulous. That positive doesn't mean positive necessarily. And then there's skin tests that are an option. So what's the protocol? And maybe this is actually a better question for Dr. Erwin.
Yeah, for sure. It's disappointing, certainly for our patients and also for us. But we don't have a great way of finding out the trigger food right now. We often do resort to the standard skin tests that we've performed just because we talked about many of these patients having associated allergic problems. So we will use the skin testing, but not for finding out the food that's causing their EOE. Unfortunately, they do have to do exactly what you described, that long, arduous process of either taking a lot of foods out all at once at the beginning, and then with repeated scopes, slowly introducing food groups back in to see which foods cause their EOE to come back, and then that would identify a trigger. Or more recently, people, academic centers have started to do the reverse, where you may take a single food out first, and then, if not better, proceed with taking another possible trigger food. So it's not an easy process.
This kind of reminds me of a show that we did not too long ago on genomic medicine. And I wonder if retrospectively you could look at the genomes of people who have had specific food triggers and then use that in the future to predict, then you look at someone's genome that has EOE and say, oh, because you have this genomic characteristic, then it's more likely that these foods could be a problem. Is that something that it'd be a big research project?
Yeah, that's a great idea that I might steal. But yeah, I think perhaps with the increase in genomic testing that we have available to us now, that may be a great way of personalizing medicine for the EOE patient too, and being able to identify their triggers.
Yeah. And not just from a food standpoint, but also from a medicine standpoint, which is where we were heading before I interrupted you. So Rajitha, why don't you continue?
Not at all. That's exactly right. And I think as we better understand transcriptome and genome, I think that exactly is going to be this next phase and hot topics, which we'll talk about too in terms of EOE research. For medications right now, the most common things we often talk about are topical steroids that essentially swallowed fluticasone or budesonide are swallowed form of an asthma inhaler or mixture to control inflammation, suppress the eosinophils. We very rarely use systemic corticosteroids, particularly not for chronic management of the disorder in general as well. Another category, which we've talked a little bit about, was acid suppressors like proton pump inhibitors or PPIs that may help relieve reflux symptoms in some patients in combination with dietary therapy or other medications. But we also actually are learning that PPIs may have an anti-inflammatory effect by reducing the production of eotaxin 3, which is one of the key chemokines that allow eosinophils to go into the esophageal mucosa. And we'll talk a little more about another medication called dupilumab, which was just very recently FDA approved, which is incredibly exciting. It's the first FDA approved medication for EOE. And so this is a really exciting new chapter of treatment for eosinophilic esophagitis. And the last couple one things I want to mention is dilation. So this sort of comes down to complications and things. If the esophagus becomes too narrow as a result of EOE, it can actually cause food to become stuck. And we said that was called a food impaction. So a dilation is actually where we, as a gastroenterologist, can stretch the narrowed esophagus to help ease symptoms and to help actually food move a little bit easier. And it often involves inflating a balloon or inserting a tube to help stretch it out. And ultimately, the decreasing dysphagia, just helping patients and families, even once their EOE is healed, to feel safe around eating food. So feeding therapists actually are pretty heavily involved in coaching patients through what they can eat and even things like pill swallowing so they can start to feel more comfortable with that as well.
Yeah. So the esophageal dilation is something that especially if there are complications like strictures, that would have to be opened up so to reduce dysphagia and the chance that food getting caught.
That's exactly right, because it is a chronic disease that requires ongoing monitoring and management. And even though EOE doesn't appear to limit life expectancy, there's currently no strong data suggesting EOE causes any cancer of the esophagus, which is incredibly reassuring as well. However, if left untreated, EOE is complicated by the development of strictures or esophageal narrowing, which may cause food to lodge in the esophagus. And it can also make eating very difficult and uncomfortable for children and adults. And it's not really exactly clear how long EOE has to exist before strictures form, but we do know that the natural history of EOE is continuing to emerge, and careful monitoring and long-term follow-up is advised. So that's where things like an esophagram, where we actually can see if there's stricturing in their esophagus, can be helpful. But really the big part of this is just trying to better monitor and be involved with the patient's family over the long haul.
Yeah. So when we think about complications for poorly treated EOE, we mentioned, discomfort, problems with swallowing, but then secondary to that can be malnutrition, poor growth, poor development. So those are also things that we would reasons to treat this aggressively.
And that's exactly why it makes it even more challenging, is that sometimes symptoms actually may get better, but internally the esophagus may not be completely healed. And that's where serial monitoring with endoscopies is important, sort of help put that all together. So that's often the challenge we see is, let's say we get to a point where patients feel better and may even be lost to follow-up potentially because of that, or may not continue with therapy. We do know that it's a chronic illness and it will continue on, and the inflammation will continue.
Before we get too much further down the road, you had mentioned that there's a newer treatment out that's very exciting. What was that again?
Yeah, so in 2022, last month actually in May, dupilumab or Dupixent was approved by the U.S. Food and Drug Administration, or FDA, to treat adults and children 12 years and older with EOE. And this is the first FDA-approved treatment for EOE, which is incredible, as really during the entire duration of this illness, we have not had an FDA-approved medication for this.
Is that a monoclonal antibody?
So we actually... Oh, go ahead. Sorry.
Yes, yes, it is. It's an antibody against the IL-13 receptor, but it not only does it affect IL-13, but it also affects IL-4. And it seems like with that combination, we're seeing great success with treatment.
So it's blocking the chemical signals that are pulling eosinophils to the esophagus.
Yes.
And it's actually already used in other medical conditions like eczema and asthma currently.
Great. Very interesting. Okay, so we talked about complications of this being poorly treated. We also, as we think about risks and benefits and kind of walk families through informed care, we also want to think about any risks with the treatments that we do. And so what kind of concerns do we have for the treatment of eosinophilic esophagitis? And this kind of discussion, I feel like, is really important for primary care doctors, because a lot of times they'll go, patients will go see the specialist. They're told, hey, do this medicine. And for some reason, the parents don't think about their questions until they get home. And then they go see their primary care doctor and they're like, should I be worried my kid's swallowing a steroid every day? So, what should we tell as primary care doctors, what should we tell parents when they have those kind of questions?
Yeah, that's an interesting question and a conversation that we have all the time with our patients, for sure. And it, if you think about it, we've just talked about several different treatments that patients can have. And so, really each individual treatment has sort of its different set of risks. Even with diet, you can have the risk of a patient who's already not growing well, refusing to eat and, perhaps having their diet become very limited so that they're not getting the minerals and nutrients that they need. And so, even diet, I would say, is not without risk. But from a medicine standpoint, I would say we get a lot of questions now about proton pump inhibitors, which is often one of the first treatments that patients are started on if they're going to take a medication. And so there's been concern that there could be long-term effects after people have used it for years and years. And I think so far, we don't think that there are risks in our pediatric patients, and we have patients who do take it for an extended period of time. But we also always talk about how there are all these other new treatments coming down the road, and so a treatment that we start patients on now is not going to be a treatment that they're on forever. So I'm not as worried for my patients about long-term use of medications as I think we would have been in the past. We think steroids, all reassuring data. We often look at the asthma literature, but it's still being studied for EOE as well to see if there are different risks. But so far, we're not seeing problems or doing much additional testing or screening for patients who are on those medicines.
Yeah. And as we walk families down risk versus benefit, I mean, obviously there's discomfort involved. There's a kid who's not eating well, maybe not growing well. There's a lot of frustration there. And so you would think really with what we know as of right now today, that the benefit of these management ideas is really going to outweigh any risks that there might be.
Yeah, for sure.
Yeah. And then, of course, we ought to mention, too, the risk of dilation, which is more in your scope, Rajitha. You certainly can stretch too much, and that could cause a problem, but you're certainly on the lookout for that kind of issue.
Actually, it's a great question, and we do actually have several studies that have looked at this, and the risk of perforations is actually incredibly low. So we know it's actually relatively well tolerated. It's actually incredibly safe to do. When we think about sort of the emergency issues like the food impaction, those are actually probably our most highest risk patients who come in urgently with food stuck, and we actually have to remove it at that time. So I think often when we think about dilation, I actually consider a really safe part of that therapy, and it may be that they may need it intermittently and not necessarily, maybe at the initial part of the diagnosis or down the road, depending on sort of how their EOE is developing. And that's actually where we're looking more into different types of endotypes of EOE, if it's more fibrostenotic or more inflammatory. And so that's actually a lot of where some of the newest literature is coming out too.
So that's really looking at the histology and those characteristics then to help you come up with a plan.
Yeah. And actually even things like distensibility of the esophagus. We have a new technique called EndoFlip that can actually measure distensibility of the esophagus, which we don't get a great sense when we do our scope because when we actually go in, we actually are inflating the esophagus a little bit. And even if we're able to pass the scope, it doesn't give me a sense of motility, for example, or how well the esophagus is able to squeeze and move. So we have a lot of great new techniques to help us better understand how to incorporate this as part of a treatment plan. And I just wanted to also echo just in terms of dietary therapies, I think, we talk a lot about the benefits because I think a lot of families want to be able to identify like, this is my child's trigger and we just avoid this. But it's certainly, even in light of, the formula shortage right now and thinking through all that, it is something that the, quality of life, it can be challenging, especially since food is such a big part of our diet and culture, that, there are some downsides to sort of all of our therapy options, but really trying to weigh in on what's appropriate for that child and family. And particularly younger children might be a little bit easier to start trying to look through diet options and help create a medical and treatment plan for the family.
Yeah, absolutely. Speaking of those treatment plans, Elizabeth, what's the long-term outlook for kids and families that are impacted by this condition? Is it something that, you get it under control and it stays away? Is it something that kind of comes and goes? Does it progress and, does it continue into adulthood? What can these families expect?
Yeah. So our information about the long-term or natural history is a bit limited since this is a newer disease. it's hard because all the information we get is from adults who have it now, but we don't know what it was like for them when they were younger. And of course, for the kids, we're still watching them, get older and trying to follow what happens for them. But we do definitely think that this is a chronic disease. This is not like IgE-mediated food allergies, where we often tell patients that they'll outgrow it. So unfortunately, once patients are diagnosed with EOE, they're in it for the long haul usually, and it's hard to stick with treatments for indefinitely. And so often we'll have patients who start or stop therapy just because of life and different things that happen for them. But we mostly find that it comes back if patients completely stop their treatment. They can certainly shift gears. So, maybe a patient who's treated with diet at first gets older and the diet is more difficult when they're more social and they're not always eating at home. And so sometimes those patients end up on medications, if they've expanded their diet and they're not seeing immediate symptoms, but their EOE comes back, we'll have patients shift gears. But we really do think that they need to stick with treatment to keep the eosinophils from returning.
Yeah. The typical treatments that we're using now, do they work most of the time? I mean, are there kind of refractory cases that are more difficult to treat?
Yeah, interestingly, it seems like what works for one patient is not necessarily what's going to work for another. So it really would be nice to have that sort of personalized clue like we talked about earlier. But I would say for each of our separate treatments, we have sort of this expected, response group overall, response to treatment. But for the individual patient, we don't know until they start their treatment. And then, as we've talked about, we can monitor their symptoms, but we need the scope to make sure that they have mucosal healing inside too. Yeah.
But in your experience, once you kind of try, the food modifications and the different medicines, you're usually able to find something, right? For most of these kids?
Yes, I would say. I mean, we see a lot of patients. Our combined clinic sees a lot of follow-up patients because it really, it doesn't happen immediately for all patients. And of course, there's so many outside factors like adherence, insurance, a lot of other things, but it can be a challenge in some patients to get things under control for sure.
Yeah, I'm sure that's disheartening for some parents, but it does make it even more important to understand like why their kids are taking the medicines that they're taking, and that's also a role of a primary care doctor. If you really understand why these medications are being used, and then when kids come in for their well checkup and you're just checking to see how things are going, that you could ask, hey, do you have any questions about your medicine? Because if they have another provider who's kind of demystifying what those medications are doing and reinforcing the importance of them, then that may really help to continue folks taking medicine like they're supposed to.
Yeah, that's a great point. And patients do have so many questions about this since many people don't know much about it going into things. So it is helpful for them to hear from multiple providers and to get some sort of consistency in what they're hearing too.
Yeah. Is there a way to prevent eosinophilic esophagitis from occurring in the first place?
I think the answer probably is no. No right now. We've talked about risk groups. And so there are patients that, we monitor for other problems, but I mean, right now there's nothing preventive that we can say. We don't know. You might wonder if diet could be the answer, if they're on the right diet, since food causes this, will that keep it from happening? And we're not there yet.
Yeah. You could kind of look forward to a day where, this is running in families and the genomics of it and what medicine works. And so then perhaps risk benefit, factors come into mind of using some medicine in a preventive way. But that's really looking off into the future and not the reality of practice today or the treatment of this.
Mm-hmm. And it really is because it's such a new disease. I think when we think about the lifetime of just disorders. This is so new. We've really been only studying for about 30 years. So we have come a long way in a short time, but we definitely have a lot more ahead of us.
10 years from now, we'd probably be having a very different conversation, but that's true for a lot of medicine.
Absolutely. Absolutely. Even a month ago till now, things have changed.
Well, that's true in terms of the approval of the medication.
And it can definitely be overwhelming. And I think that's often affects the entire family. And I think, really having, and we'll talk more about our multidisciplinary program, but really trying to, with proper treatment, individuals with EOE can successfully manage this condition. And I think really does not inhibit them from leading full and fulfilling lives.
Yeah, absolutely. So we've talked about some of the hot topics in EOE research. Are there some other things that we ought to be clued into?
Sure, absolutely. I would say definitely we've hit on a lot of it, but research is really underway to develop medications to help block the proteins produced as a result of the EOE transcriptome and tissue inflammation. We talked about one already, dupilumab, but there's also additional research being done on other eosinophil growth factors like IL-5, for example, eosinophil depleting antibodies, as well as other medications that have not yet been FDA approved, but early clinical trials look very promising. We're also looking at, less invasive ways to monitor EOE. One of the big hurdles is that this is a condition that we monitor at this time endoscopically, which means often multiple repeated sedated procedures. Often, particularly in that first year of diagnosis and trying to achieve, what we call mucosal healing or remission of the EOE. So now we have some less invasive ways like transnasal endoscopy, where we actually insert a very tiny endoscope through the nose without any sedation, and is really well tolerated and actually, is able to be done without all the other things that we think about when we have to have a sedated procedure. There are also other testing things that are coming out down the pipeline, like the esophageal string test, which is also a less invasive way to monitor for disease activity as well as genetic markers, which you were mentioning as well. And then we also briefly hit on things like EndoFlip to better understand how the esophagus functions from a motility and sensibility perspective. And there is something called the Consortium of Eosinophilic GI Disease Researchers, which is actually part of the Rare Diseases Health Clinical Research Network that's supported by NIH. And they really are working together to improve the lives of individuals with EGIDs through innovative research, clinical expertise, and education. And there's actually several nonprofits as well, like the American Partnership for Eosinophilic Disorders and the campaign urging research for eosinophilic disorders cured in AVFED that are helping support the communities associated that have these illnesses as well.
Yeah. Really important things. And we'll put links in the show notes to some of those resources so folks can find them. Because really, especially when it's a rare disorder, you may not know anyone in your neighborhood or your community or, wherever your social circles are physically. But, having a group that's really more national that can connect you with other people who have similar challenges can really be helpful, right?
Absolutely. And they actually have conferences geared towards patients and families to meet others in the community with these illnesses. So that way they have that support network and system in place.
Yeah, very important. So check out the show notes over at PediaCastCME.org, and we'll have some links for you with regard to those resources. I love that this is a multidisciplinary program for these kids. So we're talking to gastroenterology and allergy today. I'm sure that you guys also have links to psychology, to social work, to nutrition, all of these all of these specialties within pediatrics that you can pull in and hopefully at one visit take care of the whole child.
That's a great question. Yeah, absolutely. And that's actually what we offer here at Nationwide Children's is a multidisciplinary program where we're really trying to care for the whole patient. This is a lifelong disease, and we spend a significant portion of our time really on the shared decision-making on what aspects of treatment might look like for that patient and family, what's the right approach at that time and that stage of their life, for example. And I think, when we sort of include that also, in addition to psychology, social work, dietitians are very important as well, and feeding therapy as well. And actually our pharmacists too, who play a big role in helping to work with families, improve adherence, compliance, or understanding, because, this can be really overwhelming and really affects the entire family. So having a really positive attitude and focus on sort of how to look into next steps and think through this longitudinally is really important. And so we, having sort of continued ongoing care with us is incredibly important. And just to sort of go back to a little bit about the diet as well, there really is a need for consistent national coverage and reimbursement of foods for special dietary use by children. chronic diseases or conditions, including EOE, that really require these special interventions. And so our national organization, or NASPGHAN, the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition, is educating federal policymakers about the importance of this issue through something called the Medical Nutrition Equity Act. So keep an eye out for that, and we'll share links to that to find out more about how to support that as well. But currently, especially with the shortages that we have now with specialized formulas, this is of utmost importance to make sure that we are helping to support our patients and families.
Yeah, absolutely. Tell us a little bit more about gastroenterology at Nationwide Children's Hospital. You don't just take care of EOE. There's a lot of things that you guys care for.
Absolutely. Yeah. No, we have a wonderful division here, and it spans the scope of all the way from like transplants, including like liver transplant, pancreas, for example, through inflammatory bowel disease, disorders of motility, for example, as well as to, helping patients with, milk protein intolerances, constipation, sort of the span of gastroenterology. So it's really a wonderful field, and it involves both sort of the medical side, but also the procedural side, where we actually do procedures and techniques to help patients live a meaningful and fulfilling life. Yeah.
And we'll put a link to gastroenterology at Nationwide Children's Hospital in the show notes for folks who would like to learn more about your division and what you do. And then, Elizabeth, tell us more about allergy and immunology at Nationwide Children's.
I would say similarly, we see so many interesting things. Food allergy really has come to the forefront. And so we have our new food allergy center even dedicated to caring for those patients. But really immune dysregulation, which we kind of talked about how many different things can be associated with even EOE. And I wonder if the connection is just the immune system. And with the increase in genetic testing and, and the knowledge that we're getting about those things, we find ourselves in new territory all the time from an immunology standpoint as well.
Yeah, absolutely. And we'll put a link to allergy and immunology at Nationwide Children's as well, so that folks can find out more about what you do, again, with a link in the show notes. Other links that we're going to have some up-to-date articles, and we do this from time to time. A lot of you probably in the audience have access to up-to-date and may not even know you have it. But if you're on the medical staff at a hospital or with an academic institution, you probably have access to it. And in my opinion, if you're in a group practice, it's probably worth sharing the cost for access to it, because you can really look things up on the fly and it's kept up to date. It's like having every medical textbook at your fingertips. And so I did find some good articles and up to date on EOE, and I'll put a link to those in the show notes as well, so folks can check those out. So once again, Dr. Elizabeth Erwin, pediatric allergist at Nationwide Children's, and Dr. Rajitha Venkatesh, pediatric gastroenterologist at Nationwide Children's. Thank you both so much for being here today.
Thanks so much, Mike. This has been great.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks again to our two guests, Dr. Elizabeth Erwin, pediatric allergist, and Dr. Rajitha Venkatesh, pediatric gastroenterologist, both with Nationwide Children's Hospital. Don't forget, you can find us wherever podcasts are found. We are in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android, including a new one, Good Pods. Also, I want to remind you, our landing site is PediaCastCME.org. You'll find our entire archive of past programs there, along with our show notes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show, and we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. You've listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. It's an easy thing to do. Simply head over to the show notes for this episode, episode 76 at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, you'll want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also, don't forget about PediaCast. That is our evidence-based podcast for moms and dads. Lots of pediatricians and other providers tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. It's also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.